So our next speaker is Annemarie Docherty from University of Edinburgh, and her talk is on myocardial injury in critically ill patients with cardiovascular disease, and she's going to talk about undiagnosed, modifiable, and associated mortality. Yeah. Thank you.
Good afternoon, and thank you very much for the opportunity to present my research this afternoon looking at myocardial injury in critically ill patients with cardiovascular disease. So around about 7 million patients in the UK have cardiovascular disease, and they make up around 25 to 30% of our ICU population. The myocardium extracts around 75% of oxygen at rest, and atheromatous plaque formation further reduces the oxygen supply to the myocardium. When we then add in critical illness with tachycardia and hypotension, reducing coronary artery perfusion, and an increase in global and myocardial oxygen demand, we have a very vulnerable myocardium. And so my hypothesis is that patients with coexisting cardiovascular disease benefit from higher oxygen delivery to the myocardium during critical illness. So one of the main determinants of oxygen delivery to the myocardium is hemoglobin. And in intensive care over the last 20 years, we've used increasingly restrictive transfusion thresholds, which have been shown in trials to be safe for the majority of ICU patients. And we now use a standard transfusion trigger of 70 grams per litre. So I was concerned that the risk-benefit ratio may be different in patients with cardiovascular disease because of their vulnerable myocardium. And so I undertook a systematic review and meta-analysis looking at the effective restrictive versus liberal transfusion strategies in patients with cardiovascular disease. So we found no difference in mortality between patients randomized to restrictive and liberal transfusion thresholds. However, when we looked at new events of acute coronary syndrome, we found that patients with coexisting cardiovascular disease who were randomized to a restrictive transfusion threshold had a 78% increased risk of new acute coronary syndrome compared to patients who are randomized to a more liberal transfusion threshold. And so this is the first evidence to back up that biological plausibility that patients with cardiovascular disease may benefit from a more liberal transfusion threshold. So there were a couple of limitations with the systematic review. The first was around the definition of acute coronary syndrome, which varied between different trials. And the second was due to the person who diagnosed the acute coronary syndrome and whether they were blinded to the transfusion threshold, raising the possibility of ascertainment bias. And the diagnosis of myocardial infarction in critical illness is particularly difficult. So the majority of our patients are ventilated, sedated, or delirious, and so they're unable to complain of those characteristic signs and symptoms of chest pain and shortness of breath, which then start that diagnostic cascade of cardiac enzymes and ECGs. And so to address this, I designed, set up, and ran a prospective observational multi-center cohort study to look at the dynamics of troponin in critically ill patients with cardiovascular disease. And its two main objectives were to characterize the incidence of myocardial infarction using a systematic approach with systematic daily troponins using a highly sensitive assay for 10 days, blinded from the clinicians, and daily ECGs for the first 5 days, which were interpreted by cardiologists, blinded to clinical details and to the troponins. So we recruited 276 patients across 11 sites across the UK. And we mapped the myocardial infarction onto the universal definition for myocardial infarction. And so infarction requires a rise and/or fall of troponin above the sex-specific upper reference limit, along with dynamic ECG changes consistent with ischemia. Injury is a rise and/or fall of troponin without those ECG changes, and may be acute with the rise and fall, or maybe chronic with just a level above the sex-specific upper reference limit. And no injury is patients without a troponin rise. And so we found, using this systematic screening, that actually 24% of critically ill patients with cardiovascular disease were categorized into our infarction category. And this compared significantly to the 12 patients who were diagnosed clinically, or the 4%. And in fact, when we look at that further, only 3 of the 12 patients who were diagnosed clinically actually fulfilled the universal definition. So of the 24% of our patients who were diagnosed with infarction, over 95% of these were not recognized by the clinicians. We looked at whether this was related to 6-month mortality. This is a survival plot going out to 180 days, with no injury in red, injury in green, and infarction in blue. And there was a statistically significant difference between no injury, injury, and infarction, with lowest survival in infarction and highest survival in no injury. So we looked at this further by dividing the patients into by 2 into the most sick and the least critically unwell groups. And we found this really interesting finding where there was a persistent high mortality in patients who had infarction in the less critically unwell groups. And this suggests that the mortality attributable to myocardial infarction may potentially be more in the less critically unwell than the more critically unwell groups. To investigate this further, we performed a mediation analysis to explore the relationship between illness severity and 6-month mortality. So we have the exposure of illness severity and the relationship with that with 6-month mortality. And we're using the mediator myocardial infarction to explain this relationship. So we have a direct causal pathway where illness severity causes 6-month mortality. And we have an indirect causal pathway where illness severity influences myocardial infarction, which in turn influences 6-month mortality. So we found that there was a significant relationship between illness severity and 6-month mortality, and myocardial infarction and 6-month mortality. We found that there was the expected relationship with the direct pathway between illness severity and mortality. But we found that myocardial infarction partially mediated this response and was potentially responsible for around 37% of this relationship. And so this is important because this suggests that efforts to modify myocardial infarction may be able to modify 6-month mortality. So we found that the true incidence of infarction in critically ill patients with coexisting cardiovascular disease was 24%, and that over 95% of these were not diagnosed clinically. There was a significant association between myocardial infarction and mortality, and that infarction may be on the causal pathway to mortality, suggesting that efforts to modify infarction may be able to modify mortality. So our systematic review showed that more liberal transfusion thresholds of at least 80 grams per litre should be used in cardiovascular disease patients, and this has been taken up by several national guidelines. We should be screening for myocardial infarction in these critically ill patients with cardiovascular disease in whom we are missing so many infarction events. And we should now have the opportunity to develop personalized medicine trials where we can aim to manipulate the oxygen supply-demand imbalance in order to potentially modify infarction rates and mortality. And obvious targets for these are hemoglobin and the avoidance of hypotension or maintenance of mean arterial pressure, and the avoidance of tachycardia, which will both improve coronary artery perfusion. So I'd like to thank the funders for my PhD, the National Blood Service and the Scottish National Blood Transfusion Service, my PhD supervisors, Professor Tim Walsh, Dr. Naslone, and Dr. Simon Stanworth, and all the sites for Tropical who helped to recruit our patients. Thank you.
That was great. Questions? Maybe I can just start off and say we're hearing a lot more now about gender differences in myocardial infarction between men and women. Is gender an issue here, or do men and women have the same sort of susceptibility?
Yeah, so we used the universal definition with the different sex-specific upper reference limits. Okay. So we sort of built that into our original definition and categorization of infarction. When we added infarction into the multivariable model, So we did do that. So sex was a non-significant marker, but it was certainly in there, and I think it's important to keep in mind.
Okay, great, thank you.
Can I just challenge you whether you think it's reasonable to affect clinical guidelines on the basis of a retrospective analysis without any prospective head-to-head verification of that data? It seems a very brave thing to do.
So I certainly think that there is room for a trial, specifically in patients with cardiovascular disease, looking at hemoglobin thresholds. I think one of the important things from the systematic review, so they were all trial data, it wasn't observational data, and they all had trends in the same direction. So the relative risk in each of the trials for new events of acute coronary syndrome all favoured the liberal transfusion threshold. And then when added together, that became a statistically significant effect.
Okay, yes.
Do you know what proportion of these patients are actually on a ventilator, and how the FiO2 relates to the change in partial pressure of oxygen and the impact of that on the hemoglobin level?
So around about 2/3 of our patients were on ventilators. So we haven't looked specifically at sort of the different ventilator settings. You know, this was a sort of an observational study designed more to look at the dynamics of troponin, and I think that'd be a very interesting thing to look at. Thank you.
Okay, any other questions? Yes.
Thank you. Do you control for the reason for admissions to ICU?
Yes. So we categorize. So there's a limitation due to the size of the data set, but we categorize patients both by whether they were emergency surgery, elective surgery, or emergency medical, and then further in sort of diagnostic category. So whether this was respiratory, cardiovascular, renal, GI, neurology, and I think there's one other. And that's consistent with sort of the Apache sort of classification that we use in Scotland.
Neil?
Just about
Don't try.
really interesting study. So how would you advocate picking up these hidden MIs on intensive care? What do you think we should do? How do you think we should change practice to pick? I mean, it's an amazing percentage, isn't it? Nearly 1 in 4.
Well, I think it is, yes. So essentially saying that, you know, these people are having heart attacks whilst they're sleeping and we're not picking them up at all. And I think sort of one of the cautions that we need to take with this is whether this, you know, whether these are causally related to mortality, whether this is something that there is nothing that we can do about. And I think, you know, we need the trials looking at the interventions to see whether, you know, so we can modify the infarction and then modify outcomes. But I think all patients with cardiovascular disease should get an ECG at least on admission. They all have, well, they often, we found in our study, have baseline abnormal ECGs, so they need, you know, sequential ECGs in order to pick this up. They are a really high-risk group, and if we saw them in the community, you know, or in A&E, we would be doing ECGs on them. And there was a staggering number trying to set the study up when actually we found that ICUs just don't do ECGs at admission for any patients.
Thanks.
Thank you.
Is somebody at the top there?
Hi, sorry, so why are these not just type 2 MIs in the traditional sense that the systemic causes for myocardial to be underperfused and that this is unlikely to be reversible with therapy that's indicated for type 1 MIs?
So I think that the majority of these are type 2 MIs. So type 2 is an oxygen supply-demand imbalance. And certainly out of the patients that we categorized into infarction, the vast majority, well, all of them were on high-dose or medium-dose vasopressors. And despite that, a large number of them had a mean arterial pressure under 60, a lactate over 2, and were significantly anemic. So I think the question is, you know, is there anything that we can do about them? So some of them, I think, will be type 1 MIs, so a plaque rupture, you know, and they can be treated in sort of, you know, clinical characteristic sense going for primary PCI. But for these oxygen supply-demand imbalance patients, you know, do we need to be looking more at preventing these? You know, so do we need to, you know, change our management and, you know, start with these higher mean arterial pressures, try and prevent the tachycardia to maintain coronary artery perfusion, you know, start them off with higher transfusion thresholds in order to try and maximize that oxygen supply-demand and prevent it from happening in the first place.
Do we have one last question up here? I thought I saw somebody.
I think it's there.
Yes, sorry.
Hi. So, did you control for the renal function I guess it's related to the other question about confounders.
Yes, so yes, we did. So interestingly, so we accounted for it in our illness severity model, and it was part of the sort of the daily SOFA scoring. So we've accounted for it statistically. But more interestingly, I think when we looked at the rise and fall pattern of troponin, we looked at it over the 5 different categories in SOFA, from sort of no renal injury right through to renal replacement therapy. And we found the same acute sort of rise and fall pattern of troponin across the different categories. So I don't think this is a failure of troponin excretion. I think this is an acute hit, despite sort of renal function.
Great. Thank you so much. Thank you very much.
You.
Well done.